Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Welcome to another episode of Life in Sirens. Today we're talking about medical myth busters and things you've probably heard many a time that are actually wrong.
Ooh.
So if you're still hearing, you can't give Nitro an inferior MI, or maybe you need wheezing for anaphylaxis. Let's talk about that.
All right, you want to jump into myth number one?
Let's do it.
Myth number one, you have to have respiratory involvement for it to be considered anaphylaxis.
So you're telling me anaphylaxis is not just respiratory?
I'm telling you that.
Oh my
And you know what? So
God.
the definition of anaphylaxis is that it basically has to involve two or more systems.
And that one of those systems is not required to be the respiratory system.
Yes,
It's
it's not
common.
respiratory plus. It is common, but it's not the only one you need. Like, what if you have a little kiddo and we find out they're allergic to nuts, and we find out in a scary way, and they have hives and are vomiting?
Epi.
I'm counting two body systems.
That's two. Epi it is.
There's
criteria for epi.
actually a video going around right now of this girl who's literally in an ambulance, and she's like, they won't give me epi because they say I'm breathing fine, and she literally is like edematous and like has hives and looks like she needs epi. So please don't be that person, because every time I see that video, I'm like, this is the most embarrassing and dangerous thing I've ever seen.
And she,
Yeah.
I think if I remember right from that video, she like had run out of epi, so
Yeah.
that's why she went to the...
Yeah, she like went
She-
to the fire department. She just
Yeah.
drove there. And even in the ambulance, they wouldn't.
And it's so weird that we learn it that way, because I understand that oftentimes it is respiratory involvement, and that's what we learn about is like the big scary part. You lose their airway and all these things, but I don't want to wait for that.
No.
Like, if
Also-
you're waiting until they're stridorous, like, you are behind the eight ball.
Epi is the only thing that's going to fix or treat anaphylaxis. And it's also, this is a young woman with a medical history of anaphylaxis. It's not going to hurt her.
No, give
It's
her Epi.
not going to hurt her.
It's not a 95-year-old granny that says, I think I'm allergic to my Pepto-Bismol. Like, that is
Yes.
not what's happening.
No.
Right. The benefits are far outweighing the risks on that one.
Absolutely.
For sure.
Absolutely.
According to a JAMA review in 2015, up to 20% of anaphylaxis cases present without any symptoms of respiratory.
Oh.
So just keep that in your forethoughts.
If we're getting to the point of like stridor, it's big bad. We're not good. We are really far down this pathway. And in most cases, I would say almost all the time, there's been a few, but most of the time we see people with anaphylaxis, they've had an reaction before.
Mhm.
They know they have an allergy, because you just don't full blown go into like the worst possible anaphylaxis
Right.
your first time you try something.
Oh my gosh. Guys, my favorite call that we've been getting a lot of recently is like stings.
We have, yes.
Yes. And you will get there and they're like, I got stung by a wasp.
Okay.
And you're like, oh, okay, so you're allergic to wasps. And they'll be like, I do not know. Like, you have never been stung by a wasp in your whole life, and you're a 60-year-old man that lives in the middle of nowhere.
Which is impressive.
It is
is
impressive.
impressive.
And they're like, I don't know, I just called you because it stung me. And this just happens repeatedly.
It does. It happens
it's been
quite a bit.
happening like every shift.
Like, a lot. I'm
Mhm.
like, never in my life, even when I was a kid, an adult, was I stung by something and then immediately like 911. Who knows?
This is it.
The most badass thing I've ever done in my whole life, the whole life that I've lived so far, was I was like 6. I was sitting on the side of a pool, and a little bumblebee stung me. And I looked at that little sting. I pulled the stinger out, and by the way, the formal term for that is a stingerectomy, and that's actual medical definition.
I love that.
And then I just kept swimming, so maybe you should be more like 6-year-old me. I would like to be more like 6-year-old me as well.
Basically, pony up, everybody. Stingers are fine, unless you're allergic to them, and then call us.
But I will say,
just perform a stingerectomy.
You do need to actually perform a stingerectomy if the stinger is still there and they are having an allergic reaction.
Because it will just continue to get worse.
Oh, yeah, good point.
So.
And you know how you can do that?
Credit card.
Yeah, or tweezers.
Yeah, and that's actually, or duct tape.
Oh.
We have it on the truck. Tegaderm. Throwback to when Aubrey had prickly pear.
Yeah, when she picked that thing up.
Yeah.
Man, I did not know. And I should have known.
You did know. I don't know what was going on. It was a momentary lapse of judgment.
Yeah, you said this shouldn't be too bad, and then I had to look over, and your hand was just full of spines.
I was like, I know that Jamie has tegaderms because she brings them everywhere.
And she did.
And I
she had
did.
so many.
And I still do.
You saved my life that day.
Registry question. That is a registry question. Is what is it? What is a stingerectomy? That is actually like.
I love that.
I don't know.
All right, let's move on to myth number 2. Myth number 2 says you should never give nitro to an inferior MI.
Well, duh.
Debunked.
What?
You're wrong.
Oh, gosh.
Nitro is not automatically contraindicated, so we need to always assess the right things, including right-sided involvement.
Right, and like, why are we scared of nitro in a MI with right-sided involvement? Because the right side of your heart is preload dependent. And that's it. If you drop the blood pressure too low and they're dependent on preload, then their right side is going to continue to get worse.
Yes, and we have the tools to check for right-sided involvement.
Yeah, we do. Do a right side.
Yeah.
Got lots of stickers.
So they just said inferior MI, it's likely to involve your right side, even though it's not nearly as likely as you think. And just do a right-sided instead.
Yeah, if you see inferior, you should probably just automatically be doing a right-sided.
Mm-hmm.
And then also just know that the right-sided involvement is about 30 to 50% of those inferior MIs. So it is a large number, but it shouldn't always prevent you from...
It's not an absolute contraindication.
Yes. It can't be, or people wouldn't have it at home.
Right.
I mean, honestly, that freaks me out.
I know, that is wild.
Yeah, every time that they're like, well, I took 7 of these pills, I'm like, oh my God.
Yeah, that actually my very first call ever in EMS when I was on the fire department was a guy, he took 7.
Oh my goodness.
He took 7 nitro for back pain, like just like muscular pain.
Oh well.
It was his
But he was
wife's.
not feeling good.
I think it only would have helped him if he was having a aneurysm.
Yeah. Bring his blood pressure down.
Yep.
To refer.
Sheesh.
Man,
He
dang.
looked bad.
So, moral of the story, do some more investigating before you say no to nitro all the way.
Also, if your blood pressure is like 190, who the frick cares?
Yeah, we're good.
You're good. You are good. You should probably bring that down.
Yeah, we're good, homie.
All right, myth number 3. Hyperventilation lowers ICP. So just bag them faster.
Hyperventilation does not lower ICP. It should not be routinely used to lower ICP because it can actually reduce your cerebral perfusion pressure.
Yes, CPP. Yeah, and I think there was a huge focus on like reducing the intracranial pressure, but like the reason why we talk about CPP more is because your blood pressure is adjusting to perfuse your brain. It needs higher pressure to get blood.
Absolutely.
to
So,
them.
like, if your intracranial pressure is pushing down on all your vessels, essentially, then you need more pressure inside of them to be able to push blood through.
We need to keep it a little bit elevated.
Yeah. And so if you hyperventilate, the idea was that hyperventilation would reduce your PaCO2. That's going to cause cerebral vasoconstriction, which in turn will decrease your ICP because you've got less things in there, right? But it also decreases your cerebral blood flow, and then your brain dies.
Yeah, it's honestly like terrifying. What did Dr. Hunt always say? He was like, we were literally killing everybody.
Yeah,
because
he
we would
did.
just hyperventilate them automatically.
Mm-hmm.
Mm-hmm.
Yep, and we just tanked their perfusion.
Yeah.
So prophylactic hyperventilation per the Brain Trauma Foundation guideline is not recommended in the first 24 hours post-injury.
Hyperventilation is a bridge, not a treatment.
Do not hyperventilate your patient.
No, that is big bad.
It is not the move. It is not the move. Your target end tidal is still 35 to 40, and ventilate per use.
Yeah. Give mannitol.
Yeah.
Give 3%.
Yes, and if you do a lot of IFTs, make sure that they send you with the appropriate meds to manage
Yes.
ICP and your central perfusion pressure. Because like Sopha's run into.
Up the creek without a paddle.
Absolutely. If you get into that position, you have nothing to do anything about it. And some services carry like hypertonic saline and things like that. But
And truly, like, you'll even see like an awake alert patient in the sending facility. Typically will go ahead, if there is signs of increased cranial pressure at all or risk for it based on how quickly this bleed or whatever is developing, they will go ahead and hang like 3%. So just remember that your hyperventilation is just a bridge, and it's kind of like a last-ditch effort, so it's not your treatment for this intracranial pressure. Like, we don't need to just prophylactically be hyperventilating people, so just make sure if you encounter this that you have the right tools necessary. If you need to call for orders, do that, but there's no need to chase CO2.
yeah, nope.
All right, myth number 4. This is going to be Soph's favorite myth.
If
you guys have ever heard
It's
Soph's...
my least favorite myth, actually.
If you ever heard Soph's atropine rant, don't worry, you're about to hear it again. Because myth number 4 is, in symptomatic bradycardia, just try some atropine.
Yeah.
I think that we've all been told, like, we'll just try the atropine and, like, see what happens. Okay, no. We don't just try things and see what happens. That is not... No.
Right. Especially because with atropine, it always says is ineffective in high degree blocks, which implies it's benign.
Yes, it does imply that, and that's
Right.
really misleading.
Yes. What is
And-
the exact wording? Is it not recommended in high degree blocks?
Not recommended.
Let me look it up.
Yeah. And then when you look further into the explanation as to why it's not recommended, a lot of times it says it's ineffective.
Yes.
And you're said, oh, okay, well, that seems benign. So if I don't understand blocks, I'll just give it anyway. Not quite. It's actually quite dangerous in high degree blocks.
Yeah, according to the AHA, atropine is the first line for narrow complex symptomatic bradycardia. That's the whole verbiage. I need more details, all right? I need more details.
Absolutely, yes.
This is one reason, like, obviously you always need a 12 lead to confirm things. You definitely need a 12 lead if you're giving atropine. But it is ineffective in, like, high degree blocks. And I'm talking, like, second degree type 2 and higher. So if you have given atropine and your patient went into sudden cardiac arrest, there is a reason. It's not benign. It's kind of like how sometimes we have the perception that even though it's rare, like, Narcan is just safe all the time.
Yes.
It's rare.
Yes, it's rare that someone goes into flash pulmonary edema.
Yes,
But
it
it's
does.
not unheard of.
Is a risk.
For sure. And atropine is similar. And if I remember correctly, we don't know the exact mechanism as to why in high degree blocks it can cause sudden cardiac arrest.
Yeah, so they're just saying it's a paradoxical effect that occurs in high degree blocks and all the things that, because I took a deep dive. Like, anecdotally, this was happening to me, so I really wanted to learn more about it.
Yeah.
And people need to know, because I did have patients who either decompensated way more quickly than they would have without the atropine, or they did go into cardiac arrest. So if the block is below the AV node, atropine is just like you're yelling down a hallway and all the doors are closed.
Okay.
So atropine works at the SA node and the AV nodes by inhibiting parasympathetic vagal tone. So that increases your heart rate and AV conduction. So if your block is below that, so in a high degree block, they're often below the AV node.
Everything past the block is not connected to the AV node or the SA node.
Right.
So atropine's effect on those nodal pathways doesn't ever even reach what is still functioning.
Yeah, and if there is, I think from what the research I have done, if there's still some sort of, like, the AV node is trying to work, it can just get really confused by you just, like, slamming this atropine, and then it's just, then that's why we decompensate, from what I understand.
Which would make sense. And you also mentioned that it has like a paradoxical reaction. And we don't oftentimes always understand why paradoxical reactions happen.
Yeah.
But it would make sense if atropine's mechanism is to impede your parasympathetic vagal tone.
Yeah.
That if it has a paradoxical reaction, then it would activate parasympathetic tone, which would then worsen even probably past the degree by which it was already,
Yeah.
their heart rate was already poor.
Especially when you get to, like, those wider complex blocks, like, the reason, like, that's not, like, a vagally mediated
No.
like something is very wrong and sick.
Mhm.
So even maybe you could consider like if it is super narrow complex and just like slow, but like once you start getting to these wider, scary, like high degree blocks, like
Mhm.
you just need to pace them.
Yeah, that makes a lot more sense.
And most of the time, those patients like they're heading towards pacing, but we've been taught
atropine first.
atropine while you're getting all this stuff ready and just see what happens, and now they're dead.
Yep.
It makes me-
Absolutely. And if you really follow, like really truly, if you follow the algorithm, like your ACLS algorithm for bradycardia, if your patient is very unstable,
Yes.
atropine is not indicated.
Yeah.
Which is so interesting. So a lot of times we're like, we'll just try while we're getting everything
Yes.
set up.
Don't do that.
But don't do that. So our alternatives, you mentioned pacing. So our transcutaneous pacing.
Epidrip.
I love a good epidrip.
Little push dose pressor action.
Yep.
There's
And-
other options to build a bridge.
Yes.
Atropine is not a strong bridge.
And if you're still carrying dopamine,
I'm afraid
that
of
is
you.
still
There
I
is a
know.
on the
place.
algorithm.
There is a place for dopamine, but we need to know much, 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 much more about the patient.
all right, myth number 5. What you got?
Myth number 5 is dextrose and head bleeds will make the patient sicker.
Yeah, don't give it.
I love that you're playing devil's advocate.
Don't do it.
Very passionately over there.
Yeah, don't give that.
Hypoglycemia is also a medical emergency.
What?
It's
Oh,
crazy.
my
Stop
goodness.
talking crazy.
Oh my goodness, so you do give it?
So you're telling me that somebody's going to die from being hypoglycemic faster than they'll die from a head bleed?
Yeah.
That's
yeah.
crazy.
Maybe probably not. I don't know. Depends how bad their bleed is.
Potentially not.
Their blood sugar of 2.
Yeah.
But imagine, or like our myth earlier, you have increased ICP, your central perfusion pressure is bad, and you have no glucose.
Also,
Like,
guys,
brain
yeah.
is in bad shape, you know?
Most patients with like neurological emergencies will eat through glucose because
Mhm.
the emergency is inside their brain.
Mm-hmm. Where
Brain
you
It
lose.
eats sugar.
Yeah, you use so much of it.
Brains, lobe, oxygen, and
yes.
sugar.
So the American Stroke Association recommends obviously checking and correcting all glucose in any patient with stroke-like symptoms. So the hyperglycemia over 180 could be associated with worse outcomes after admission, but not during initial EMS care.
All right, I like that. So
Yes.
really, we don't have to change our practice, but if we want to be cautious, we can.
Yes.
You know, give things slowly,
Yeah.
recheck frequently.
Give D10 rather than like D50.
Right. Don't just push a whole amp of D50. you know?
Right. Which we're moving to, because why were we doing that? That's crazy.
Why? I
It's
know.
just harder work for
We
everybody.
were like, hey, if your IV's not good, this will make their whole arm necrose off.
Yeah, and you're
We
diabetic.
could dilute it, but we're not gonna.
Yeah, that was why
That
did
was
that's so
wild.
crazy that.
They're like, you can dilute
We're
it
not
for
gonna.
babies.
Yeah,
but
but,
for
not
adults,
grown-ups.
deal with
it
it.
honestly
Get it.
works so fast.
Yeah, it's great.
Uh-huh.
So, not to mention that hypoglycemia mimics stroke
Right.
symptoms.
How are you gonna call a code stroke if you?
Right. And
That's embarrassing.
man, if you have ever been in that place where you get to the ER and you forgot to get a blood sugar and you've called a code stroke and they're like, what is the blood sugar? And you look at them like, oh crap.
I would quit. I would cry. I would
And
I would
then-
move to a new state.
It's only happened to me one time.
Yeah.
And I did forget to get a blood sugar. And I was like, oh my God, oh my God, oh my God, oh my God. It was normal. Thank God.
Yeah.
You said, whoo.
Whew. But it did not happen. So you have to correct it. And missed hypoglycemia creates a major delay in both care and morbidity because they have to get the sugar up and see if symptoms resolve prior to doing anything else. Why do you think that it became a myth in the first place?
Because it's a necrotic.
Right? In my brain, I think that people thought about it almost as like a hypertonic solution.
Okay. I don't
Yeah.
know that people think on that level,
Right?
Shame.
But I'm like, but if they thought about it there and they thought, okay, well, if we put a bunch of solid or solvent basically in the brain, it's
Yeah.
going to bring water to the brain, which will increase ICP.
I wasn't thinking that advanced. I was just thinking people were like, oh, if your IV blows, then your whole arm falls off. So if we just shoot this into your head bleed, then it's just
It's probably
free
bad.
floating into your brain. That's what I assumed people
That's
thought.
what I thought too.
Yeah.
Because that's kind of what we were taught.
Worrying about a blood sugar of 130 when their glucose is currently 30 is like worrying about a speeding ticket while your car is on fire.
Yeah, there are bigger fish to fry.
Right.
Yep.
So again, be cautious. Do not like just slam a whole bag and then look at their sugar and it's 320. Like, be cautious, but also be responsible. Like, give the D10.
For sure. And before we go on to our next one, I just want you all to send us your myths. Let us know what you've heard, because I've heard some wild ones while making social media content. And there are things that I know regionally as, like, major EMS myths that people would be like, no one believes that. I'm like, no, literally everyone believes that. What are you talking about? And they're like, no, they're stupid. I'm like, no, everyone believes that.
Yeah, it's like a thing.
So write us. You can visit us at our website and fill out a little form and tell us all about it.
We want to know all your myths. So you get a bonus myth. And bonus myth is there's been more recent research into access during cardiac arrests. And our bonus myth is that IO access is the superior access in a cardiac arrest. Turns out, is not.
Which hurts my heart a little bit.
I think it hurts all of our little paramedic hearts.
It does. Now, we had a conversation about this earlier, and establishing an IV, so AC or above, in a cardiac arrest can be quite difficult depending on your downtime. Now, some people...
And your resources.
Some people don't have any problems. But the time to epi is, like, what's important. And apparently, throughout, like, a significant study and, like, meta review, it was shown statistically significant that time to epi was faster with IV access, and then your further administration of epi, so, like, your subsequent administration, goes from, like, access to heart much faster. It's, like, 2 to 3 seconds.
Which is crazy.
Right? So a tibial IO, which is the most common that we'll use in codes, because it's like, a comfortable allocation of resources. Get someone down here, someone up here. It's 7 to 8 seconds.
Which is wild.
Yeah. And then a humeral IO is 2.5 to 3.5, so comparable.
Yeah.
And then an EJ is similar to, like, it is comparable to a central venous line. So
in my brain, it goes IM, IO, IV. Like,
yes.
Yeah.
That's just,
as
I don't
far
know.
as access,
Yeah.
like the hierarchy.
Yes.
Yeah.
Yeah.
So if you're looking at just data, and we're assuming everybody is wildly proficient at each of these, then it goes EJ, IV, humeral, tibial.
Yeah, if y'all are doing tibials only, like that's in your protocols, you really need to push for
To get a
head.
humeral. Mm-hmm.
It just also flows so much better. Like, you don't need a pressure bag.
Yeah, you really don't.
Which is super nice.
Yeah.
Yeah, like you can still put one on there, and I think they still recommend that you put a pressure bag on, but truly, like when you do it, you do not need it.
It flows. It's wonderful.
It's super
beautiful.
nice, unless they have like a lot of adipose tissue or like a large body habitus.
Yeah.
It normally does not affect it at all.
And you have to worry more about, like, positioning.
Positioning is a hurdle for sure. So essentially, if you can't get an IV within 90 seconds or 2 attempts, then you should go straight to IO access, because again, it's the time to epi that is important. But after that first epi, they still recommend establishing IV access if you have the resources to do so.
Yeah. And it's okay if you can't, but do your best.
But do your best. So I just thought that was interesting, because in my brain, I'm like, man, we've all been there in the ER where you bring in a code and they're like, we don't have any access. And I'm like, you have 7 IOs. They have extra limbs that I put an IO in. Like, you have access. And then they are trying to get a line. And I just thought that they were just creatures of habit. And maybe it is for that reason, but turns out they're also right. As much as it hurts my little paramedic heart. Because for years I've been yelling, it's the same thing.
I feel like humeral head is...
I would say that is like a
very comparable
moot statistical point.
Yeah.
And the statistical data shows that, like, so survival to neurological outcome. Now, this is worth noting. Patients that received an IO, an IV, whatever their access was, it was not a statistically significant difference in their favorable neurological outcomes. It is worth noting that arrest to ROSC, so being able to get a patient back to a degree, was 50% higher in the IV group.
Which, that's crazy.
Which, if we think about epi and how that works and everything, it makes sense. But I found it interesting that there is a lot of variance in survival, like, to admission.
Which is great, but, like...
Right, but then survival to a favorable neurological outcome is.
Yeah, and I hate to say this, like, yes, it does give time for people to come visit and say goodbye, but like, what are we chasing?
Right, and that's what I was gonna say. Is I was curious as to like what you guys thought, because really, like, our goal is a favorable neurological outcome. Like, I want you to be able to go home and go back and live your life.
To be a person again.
And that's what we gear most of our care towards. Almost, well, really all of our care towards, unless your goal is palliative care. But like, that's where we gear all of our care towards. And so, are those our practices? Even though sometimes the logistics of the most ideal practice is difficult. And so, is like that middle of the road one okay?
Yeah.
You know, like, you give families time to say goodbye. Like, you know what I'm talking about?
I
Like,
get that.
Yeah.
I do. I just...
like, even though the survival to like neurological outcome, or a favorable neurological outcome, is not different, and an IO is easier to place and it's faster to place, in that argument, we could just keep doing that.
Yeah.
But if survival to admission is 50% higher in an IV group, then that's 50% more people that can say goodbye to their loved ones. But it is interesting to think about.
Yeah.
And it just, got my brain.
I think that, and this is going to sound a little crazy, but I think we're too early in the game, which sounds crazy because people have been dying for lots and lots of years now. But I think that just in a very simplistic way, to get favorable neurological outcomes, like, you have to get a heartbeat back, you know? And I just think that we still don't know. Like, we're still giving, 6 milligrams of epi on each code, you know, like, we just still don't know enough to be able to say yes or no, one or the other.
We are still potentially giving an excessive amount of medication that is the reason that we're not having favorable outcomes.
Yeah.
Like, there's no cap.
Right.
Well, and
I
have, my thing is, like, if there's zero correlation between, yes, there's an improved, like, admission rate of these patients, improved ROSC rate, that's significant. But there's pretty much no improvement in neurological outcome. That's wild.
Yeah, it's not significant. It's not statistically significant. Yeah.
And, like, we're obviously missing something. Right.
And so then I wonder, like, okay, but do we still chase that best practice? Like, we still chase the, like, establish an IV, like, as soon as possible, as soon as you can. Because what if it's something else that is not changing the neurological outcome that we're doing that's, like, way bigger of a problem?
I have this, like, conundrum.
Early defibrillation.
Right.
Well, I have this conundrum that we say, like, epi is very bad for excessive epi is bad for neurological outcome. And our goal in this study is to establish time to epi. We're trying to get epi in as soon as possible. And that just is weird to me because what are the most common arrests? VFib and VTAC arrests is what I mean.
And then we're going to dump a bunch of epi in there and push their heart.
Which is not going to solve the VFib, the VTAC.
Yeah.
So that is, there's way too many complexities, but, like,
for sure,
we need more algorithms for cardiac arrest.
All right, guys. Well, like we said before, send us your favorite EMS myths because we know that they're out there. We know that they're outrageous, and we would like to hear about them. And until then, we will see you next time.
Dry drowning is a myth.
Farewell. This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.